Now we are going to move forward with our case 1 presentation. As a reminder, we may go over just a little bit tonight, but I promise you it will be worth it if you're able to stay. Dr. Hussain, I'll let you introduce the first 2 panel speakers, and then I'll introduce the next 2.
Thank you, Dr. B. First, I would like to introduce Dr. Kemi Babagbimi, who is a board-certified radiologist specializing in women's imaging at Weill Cornell Medicine, who is currently an assistant professor of clinical radiology and assistant attending radiologist at New York Presbyterian Hospital, Weill Cornell campus. She is also a faculty scholar in health equity, an initiative of the Cornell Center for Health Equity and the Diversity Center of Excellence. I also have the pleasure of presenting my colleague, Dr. Flannery, who is a fellow of the American College of Surgery and the American College of Oncology. Dr. Flannery, who is fluent in Korean, has been recognized as a top doctor by local and regional publications. She is a frequent lecturer at professional and community educational events and serves on several committees for the Susan G. Komen Central and South Jersey. Dr. B.
Thank you. And as part of our first case presentation, we also will ask Ms. Valentine to join us. And we just want to thank her again for sharing her very important story. And I know that we're going to gain some insight from her once we do the Q&A. Dr. Anu Balagan is also going to join us. She is an assistant professor of radiation oncology at Weill Cornell Medicine, and she specializes in the treatment of breast and gynecologic malignancies. And she's engaged in global health activities, which focus on improving the delivery of radiation therapy in low and middle income countries. We also will have Dr. Evelyn Rubles Rodriguez, who's an oncology advanced practice nurse at MD Anderson Cancer Center at Cooper in Camden, New Jersey. She serves as the Director of Outreach, Prevention, and Survivorship. Ms. Rodriguez regularly writes and manages grant-funded efforts and is involved in developing patient and community programs as well as in direct care of patients. She is also one of the co-PIs for the sponsored grant for this. So without further ado, we're going to start the panel presentation. So as promised, we'll move into our breast health equity virtual case-based panel discussion for case number 1. We do have 2 cases today. We've already given introduction to our esteemed panelists and presenters today. So case 1 is a 38-year-old Black woman with a palpable right breast mass. She discovered it in May of 2020. She's employed as a server at a local restaurant in New York City. However, due to the COVID pandemic, which started in March of 2020, she lost her job and as a consequence lost insurance. She does have a family history of breast cancer with a maternal aunt who has breast cancer. However, the patient does not have any personal history of breast surgery. She did visit her primary care physician when she felt the mass, and imaging was requested. However, it was delayed due to her loss of insurance as well as the COVID-19 pandemic, which put a halt on mammography, mammogram availability as well as biopsy. Subsequently, the patient eventually received her imaging as well as the biopsy and was diagnosed with a triple-negative breast cancer with metastasis to her right axillary lymph node. And this is just a picture of New York City, which was the epicenter for COVID-19 last year. I always like to go through a timeline to just remind us March 11th was the first New York City COVID-related death. And then in April of 2020, we saw a peak in hospitalizations as well as deaths due to COVID-19. And subsequently, over the last year and a half, we have really had issues throughout the country with increased hospitalization and deaths related to COVID-19 with various peaks throughout the country. But just going back to New York City, which was the epicenter, I think this is always important to just sort of point out that what we saw early on in COVID-19 related deaths in each borough, we could see that for those boroughs that are more diverse, Brooklyn, Queens, Bronx, there was an increased rate of COVID-19 related deaths compared to Manhattan or the Upper East Side. And New York City shut down consequently due to COVID-19. We had lots of deaths at the hospital due to COVID-19. And now, as you fast forward, we have all adapted to wearing masks and having vaccinations. But I always say, just because COVID-19 started does not mean that breast cancer stopped. And so we have to remember the consequences of COVID-19 and its influence on the treatment and diagnosis that patients get with breast cancer or for breast cancer. Just some breast cancer epidemiology. It's estimated the new cancer cases in the United States for women, breast is the #1 cause of new cancers. And then we look at the estimated cancer deaths in women in the United States. Breast cancer is the second leading cause of cancer-related deaths in women. And just breast cancer incidence and mortality by race and ethnicity. You can see here, this is the incidence of breast cancer in white women as compared to Black women. So Black women are slightly less likely to be diagnosed with breast cancer. However, when you look at the mortality here, this is non-Hispanic Black women, and this is non-Hispanic white women. Black women have a 40% increased risk of mortality due to breast cancer. And it really can be illustrated here in the 1980s when the advent of hormonal therapy came about and really treated women who had hormone positive disease, which consequently was found more in white women as opposed to Black women who often have increased risk of a triple negative breast cancer. And so that disparity certainly continues to exist, unfortunately, and we know that it is multifactorial. And this is just to drive home the fact that breast cancer incidence by tumor biology and race, when you look at white women are more likely to have the hormone positive phenotype, whereas Black women are more likely to have the hormone negative breast cancer. And then when you look at stage, or when you look at the makeup of the tumor receptors age for age, Black women are more likely for each age group to have triple negative breast cancer, which portends a worse prognosis. And when we look at breast cancer survival by stage and race, we see stage for stage, the survival for Black women is less for each stage. So what is the breast cancer burden of Black women? Well, their socioeconomic status disadvantages. We talked about the higher mortality due to breast cancer and that the cause is multifactorial. Black women are often diagnosed at advanced stage, often diagnosed or more likely to be diagnosed at a younger age, and have a twofold higher rate of triple negative breast cancer. So what about breast cancer disparities in the COVID-19 era? So socioeconomic disadvantages have led to loss of employment and as a result, loss of health insurance, which consequently leads to decreased access for patients. And then we should talk about really the digital divide. And I think that this is important to highlight. What is the digital divide? Well, when COVID-19 came about, we were all very eager to see our patients, and we switched to virtual, which increased access for some. But what we found is that access for all patients are not the same. And so there is this disparity in access to healthcare via virtual means. I mean, think about a patient who may not have Zoom on their phone and may not have one of the high-tech phones. Our elderly patients who may not have the same access. And so there is this digital divide that we have to think about and be thoughtful of. And for the patients who are treated at public hospitals then and now continue to be devastated by the aftermath of COVID-19, and really just as we continue to treat COVID-19 patients. And we also have to think about the hiatus. When New York City and the rest of the world were shocked by the beginnings of COVID, with the first and second wave, there was a hiatus on breast cancer mammography screening. And, it was the right thing to do at the time because the hospital systems were so overwhelmed. We didn't have the correct PPE. Staff were getting sick. And so mammography screening was put on a halt, but then the ACR did make a statement that it was safe to resume mammography screening. What we know is that patients still have not gotten their mammograms. They're overdue. And so we're concerned that this is going to widen the gap of breast cancer disparities. So how do we narrow the disparities gap? Well, we provide care despite loss of insurance when we can. We provide access, improve access, and address the digital divide. And maybe this means access for or with navigators throughout systems. It does include novel outreach strategies, and we've tried to do this at New York Presbyterian, Brooklyn Methodist, and Weill Cornell. We encourage mammography screening. We're going in the community and we're educating that yes, it's important to still get your mammogram. Mask up, keep your hands washed, but go and get that mammogram because again, breast cancer does not stop just because COVID-19 is now a part of our world. The community engagement that we have embarked on, and we talked a little bit about this the other day, is our breast health series. And it includes talking about breast health and what to do when you need to get screened. We also increase access for mammography screening for those patients who may need off-hour screenings. And we have conducted surveys and focus groups to better understand how we can improve access for all of our patients. I'm going to pass it over to our breast imager, who is going to talk about the case further.
My name is Dr. Kemi Obagbemi, and I will be discussing case 1 as the radiologist. In my talk, I will focus on screening recommendations and risk assessment considerations, the scope and multifactorial nature of imaging disparities in breast cancer affecting African American women, the delays due to the COVID-19 pandemic, and approaches to reducing disparities from a breast imaging perspective. Our patient is 38 years old with a palpable mass, employed as a server in a local restaurant. Family history of breast cancer, maternal aunt is all that we know. No history of prior breast surgery. Mass confirmed at primary care visit, but imaging was delayed due to the pandemic. Our patient subsequently lost her job. Biopsy was delayed, but then it was performed, and the patient was diagnosed with a triple negative breast cancer with metastasis to the right axillary lymph node. This is the bilateral diagnostic mammogram performed for the palpable abnormality, triangular BB marker placed on the area of palpable concern as indicated by the patient, and demonstrates a dominant high density irregular mass in the upper outer breast. In addition, there's a similar appearing irregular mass and multiple rounded high density lymph nodes in the corresponding axilla, asymmetric to the other side. Spot compression views demonstrated spiculations extending from the dominant mass. An ultrasound was performed and demonstrated a solid irregular mass that was taller than wide in the area of palpable abnormality, measuring about 2 centimeters. And adjacent to it, not shown here, was a smaller, similar appearing mass, suspicious for a satellite lesion. Evaluation of the axilla and the patient demonstrates multiple rounded lymph nodes, which had lost their fatty hilum, which is a sign of abnormality. The biopsy was performed under ultrasound guidance of both the dominant index lesion as well as the axillary lymph node, and the pathology revealed invasive ductal carcinoma with metastasis to the axillary lymph node. We always like to start from the perspective of screening as radiologists, and rather than palpable abnormalities. So the recommendations for mammographic screening for patients at average risk of breast cancer, as endorsed by our Society of American College of Radiology, as well as the Society of Breast Imaging and the Society for Breast Surgeons, is to start screening at age 40, to perform that at annual intervals, and to continue them as long as the patient is healthy and desires to be screened. On the other extreme is the recommendation from the U.S. Preventative Task Force that endorses screening starting at age 50 and biannual screenings and the stop at age 74. As stated, we at the SBI and the American College of Radiology recommend screening for average risk women begin at 40 because our goal is to reduce deaths from breast cancer by detecting it early when treatment is more effective and less harmful. The starting at age 40 also has the greatest mortality reduction, the most lives saved and most years gained. The years lost to breast cancer are highest for women in their 40s, and about 40% of all the years saved by mammography are among women in their 40s. Specific to this patient is the fact that African American women are 42% more likely to die from breast cancer than their non-Hispanic white counterparts, despite roughly equal incidence rates. They're less likely to be diagnosed with stage 1 breast cancers, but twice as likely to die of early breast cancers. Breast cancer death rates only dropped about half as much as it has over the course of years since 1990 compared to white women. We also have data that suggests that breast cancers are diagnosed at younger ages in Black women in comparison to white women, with about 23% of breast cancers in Black women diagnosed before the age of 50, compared to 16% of all breast cancers in white women. And as we've heard, the triple negative breast cancer that was diagnosed in this patient is a subtype that's more common in Black women and tends to be more aggressive. In terms of genetic assessment, the BRCA genetic mutations are more common in Black women than in their white counterparts, although less frequent than in those of Ashkenazi Jewish ancestry. However, African American women were less likely to undergo genetic counseling than white women and were less likely to be referred for such by their primary physicians. These patients, of course, have multiple barriers, just different from lower awareness of genetic services, but many of them were less likely to access genetic services due to cost and mistrust of the medical establishment. So taking all these factors into account, the American College of Radiology and the Society for Breast Imaging updated screening guidelines in 2018, and were the first to recognize that African American women are at high risk for disease and should be screened as such. They assigned a special status and approach to African American women. And so the ACR and the SBI now call for all women to have a risk assessment at age 30 to see if they need screening to be performed earlier than age 40 if needed. This is just a summary visual that discusses the recommendations. And it states that especially in minority women, it's important that by age 30, they should have an assessment to ensure that they're not in a higher risk category. So if patients are found to be in a higher than average risk status, patients who have a genetic base increased risk and they are untested first degree relatives or those with a calculated lifetime risk of 20% or more are recommended to have digital mammography with or without digital breast tomosynthesis beginning at age 30. For these patients also and additional patients with additional risk factors, breast MRI should be used as a supplementary test to be performed annually starting at between age 25 through 30. I've included other high-risk categories for completion. This is a summary chart detailing all the different societies who basically also agree that screening for patients with genetic mutations or lifetime risk of greater 20% or greater should start their screening evaluation at age 30. In discussing screening with patients, it's always important to allow them to understand that screening may lead to recalls and what we call diagnostic assessment. So out of every 100 women who get a screening mammogram, 90 of them will be told that their mammograms are normal, but about 10 of them will be recalled or asked to come for additional imaging assessment. Out of that 10, 6 of them will return to the screening assessment because their mammograms are deemed normal, but it's important to note that about 2 out of every 100 will have a recommendation for a biopsy. And depending on the risk assessment based on the imaging characteristics, the possibility of a malignancy varies widely from less than 25% to upwards of 95%. So the factors that influence imaging disparities in patients are multifactorial. The patient and their primary care physician may not be aware of their patient's risk on screening recommendations. This is heavily influenced by health literacy and language barriers from the patient. There's also fear of breast cancer, embarrassment, and the stress of the medical and healthcare system in general, which could impact the ability to seek out information about risk and screening assessment. There are also noted differences in race-based differences in provider ordering and follow-up practices, a lack of insurance or underinsurance, as well as poverty also influence the ability to seek out screening studies and medical care in general, geographical access to medical care, and then the access to the particular medical care is also heavily influences the patient's ability to get care, flexibility of the imaging center schedule, the presence of dedicated imagers, and then the technology that's available at these centers. So screening is definitely underutilized in Black and Latinx women. And compared to white women with private insurance, Black and Latinx women without private insurance often receive screening at facilities with less access to higher quality mammography, also confounded by all the other issues that we've discussed on the previous slide. It's important to note that screening and diagnostic mammograms are not cheap, and so insurance is definitely an important consideration for patients. I've given sort of a listing of the average costs at Weill Cornell breast imaging. So a screening mammogram with tomosynthesis would cost the patients close to $450 or more. And a screening breast MRI without insurance is over $2,000. And if the patient were to need biopsies, the range is over $6,000. Looking at disparities in this screening utilization, even with the use of digital tomosynthesis, a recent retrospective analysis from about 63 imaging centers basically showed that Black women were less likely to receive 2 or more subsequent screening exams. They was less likely to receive digital breast tomosynthesis, even though this has been shown to decrease the recall rate and increase cancer detection. And they were slightly older at the time of their first screen. There are also disparities noted in the assessment of patients with a total delay at one recent study showing about 42 days of delay in Black women compared to 26 days in diagnostic delay, with the patient who had experienced the total delays of greater than 45 days having a 1.6 times increased odds of breast cancer mortality. Not surprising, these delays were found in women living in lower socioeconomic status neighborhoods and in women without insurance. So many factors here sort of coincide with our patients. The fact that her screening assessment may not be complete, her awareness of her risk may not be known to her or her primary physician, her job as an essential worker and possibly lack of work schedule flexibility. It's unknown what her caregiver responsibilities were. And over the course of the pandemic, she lost her insurance. We know there was a delay in her diagnostic imaging and biopsy, but we don't know if there was a delay in actually reporting the symptoms of the palpable abnormality to her provider. We are not clear what her access to an imaging center was and what the limitations, if any, were available. So the disparities that pre-existed were confounded by the pandemic in response to the COVID-19 pandemic and in order to prevent further spread and to conserve protective equipment. Many of the healthcare centers, particularly our outpatient centers, were closed. A statement released by the American Society of Breast Surgeons and American College of Radiology called for the postponement of non-urgent examinations in about late March of 2020. And looking at the data from March to July 2020, similar to that time frame in 2019, there was an almost 85% decrease in the performance of mammograms during the height of the lockdown in April of 2020, with a commensurate decrease in the amount of biopsies also performed at that time to about a decrease of about 71%. Long-term projections about the impact of COVID-19 predict excess cancer deaths up until about 1,314 deaths associated with delayed diagnosis in symptomatic cases and those associated with reduced treatment in early stage cancer. In the modeling scenarios, the reductions in screening use and delays in diagnosis of symptomatic cases contributed to the largest number of excess deaths. So as we've seen, this is a multifactorial issue that's leading to breast cancer disparities, of which radiology and the access to care is a small but significant percentage of it. In dealing with these issues, it's important to notice the importance of the physician workforce and to note that shared race or ethnicity between patients and physicians has been shown to enhance overall health outcomes. Unfortunately, underrepresented minorities are not well represented in radiology or in medicine in general, but they tend to disproportionately serve minority and medical underserved populations. The active physicians that identify as African American stands as of a 2018 AAMC data at about 5%, with the percentage of all medical school faculty in imaging who identify as such only at about 2%, with the number only climbing very minimally to 2.31% by 2020. This has been recognized, and we are working to help correct these issues by expanding the pipeline into radiology. As physicians in breast imaging, we feel uniquely suited to deal with many of the barriers that stand in the way of our patients' screening and diagnosis. We feel that our role is important as shared decision-making with the patient, and we are an extension of the primary care relationship, and as such feel perfectly positioned to advocate for our patients. Most of our role has to center around educating our patients and our providers as to the importance of identifying African American women as higher risk populations and determining their need for earlier screening as necessary and for using the appropriate testing. As radiologists, we will need to play a vital role in leading any outreach initiatives, identify women for risk reduction, and help to develop programs to assist patients in navigating their breast care, not only from a radiology perspective, but an interdisciplinary perspective. I thank you so much for your time, and I wanted to refer you to the Society for Breast Imaging website for further imaging resources that may assist in the care of our patient. Here are my references.
Thank you for the opportunity to participate in this panel. I have no disclosures. So let's review the case. Again, it's a 38-year-old Black woman with a palpable right breast mass that she discovered. She has a family history of breast cancer and a maternal aunt, but no personal history of previous surgery. The mass was confirmed during a visit with a primary care physician, but her imaging and subsequent biopsy was delayed because of the COVID-19 pandemic. She also then underwent some unemployment issues with loss of insurance, and the biopsy was further delayed. And by the time that she was diagnosed, she had the diagnosis of triple negative breast cancer with metastatic disease in the right axilla. So what are the surgical options for somebody who is faced with a breast cancer diagnosis? We all know that there are typically two options that are presented to patients. One is called a lumpectomy, and the second option is called the mastectomy. Now, not everybody is unfortunately able to have both of those options, but a good majority of our patients, particularly in their early stage, are able to consider both of these options. And particularly for mastectomy patients, we now know that for patients who desire a breast reconstruction, that can certainly be accommodated at the same time as the surgery. When we're talking about surgical management of breast cancer, we also not only discuss the different types of surgeries, but also in which sequence that we'll go through with different types of treatments. So the historically, we almost always recommended an upfront surgical approach where patients would undergo some type of a treatment from a surgical standpoint for breast cancer, followed by other adjuvant modalities. But now we go through all of our options and risks and benefits as to whether it would be beneficial for the patients to go through an upfront surgery or to go through with neoadjuvant therapy. So what are some of the pros and cons of lumpectomy? First of all, lumpectomy is a shorter operation that leads to shorter recovery and less downtime, but it needs to be combined with radiation to make it an equal option as a mastectomy, and I'll go a little bit more into that later. Also, when you do a lumpectomy for treatment of breast cancer, the need for continued surveillance imaging stays, and so the patients will obviously undergo an annual mammogram in addition to other types of breast imaging that may be necessary, and that may be looked upon as a con. For mastectomy, pros, you may not necessarily need adjuvant radiation if you undergo a mastectomy for same stage of breast cancer. However, I'm always very careful to tell the patients as well as the referring physicians that just because you do a mastectomy does not negate the need for radiation, and you won't get out of it completely. It really just depends on your final staging, margin status, among other things. One of the pros that we can consider for mastectomy is that because we're removing the majority of the breast tissue, unless there are any issues, there's no need for any planned surveillance breast imaging on an ongoing basis. But there's a huge list of cons when it comes to mastectomy. Certainly as a longer operation, which leads to longer recovery and downtime. There are also more associated complications for mastectomies, particularly because most of the patients will want to consider reconstruction. And again, that's another procedure that's being added, leading to more complications. Another side effect, quote unquote, that I explain to patients when it comes to mastectomy also is that your breast tissue, even with reconstruction, never really will feel the same, particularly when it comes to sensation. We now are able to really offer some beautiful results from a cosmetic standpoint, particularly if the patients meet the criteria for a nipple-sparing mastectomy. But the sensation is almost always altered when you undergo the surgery, and that certainly is considered as a negative aspect of mastectomy. So some of the trials that we looked at historically in the breast cancer world, NSABP B04 trial looked at the differences between a mastectomy, lumpectomy, as opposed to lumpectomy plus radiation for an invasive breast cancer treatment. And the study showed us that it shows the same statistics when it comes to survival, whether you do a lumpectomy or a mastectomy. And so I always hone in on this result with the patients to let them know that just because you choose to do a mastectomy, it does not mean that your overall survival will be any better. When it comes to surgical management of breast cancer, we also want to also be cognizant of different options for the management of axilla. And so we have come really far with the management of axillary surgery. We've really done a lot of de-escalation. Most of our patients with the breast cancer diagnosis have had to undergo axillary dissection in the past few decades, which we have now proven to ourselves that does not lead to any better statistics as compared to sentinel lymph node biopsies. And the concept of doing what's called the targeted axillary dissection, where not only are we doing the sentinel lymph node biopsy, but we're actually targeting what we call a clipped node, which had been previously biopsied to be proven to have breast cancer in the axilla, and getting that out at the same time as the sentinel lymph node biopsy. That whole concept is called the targeted axe dissection, and that certainly is a new phenomenon that we're employing for the treatment of breast cancer. We have found through several trials that same overall survival benefits apply whether you do an axillary dissection first or sentinel lymph node biopsy. First, when you have a clinically negative lymph node for invasive cancer patients. So NSABP B32 trial is the largest randomized trial for breast cancer patients in general, where we were able to accrue over 5,600 patients, and this went on between 1999 to 2005. And we found that there is no overall survival benefit to doing an axillary node dissection as opposed to sentinel lymph node biopsy. And then we went further with ACOSOG Z11 trial, which is one of our landmark trials in breast cancer world, which was done between 1999 to 2004, where we looked at almost 1,000 patients with early stage breast cancer undergoing breast conserving therapy with lumpectomy and radiation, where they started off with clinically negative lymph nodes, and upon getting the frozen section, and if they happen to have one or two positive lymph nodes, do we really need to proceed with a full axillary node dissection? And Z11 trial showed us that there is no difference. So again, here's a graph from the NSABP B32. We see that whether you do a sentinel lymph node biopsy and with the axillary node dissection, the conventional axillary lymph node dissection does not lead to any better overall survival findings for clinically node negative patients with breast cancer. And ACOSOG Z11 trial also showed us that overall survival as well as disease-free survival were really the same, whether you had a full axillary node dissection or not, for patients who had even those sentinel lymph nodes that were involved with the cancer. And this is again looking at 10-year overall survival from the Z11 patients. What's also very interesting is the axillary management of breast cancer patients and the concept of that and what happens to it for patients who are able to undergo neoadjuvant chemotherapy. So there are differences. Why does somebody undergo a neoadjuvant chemotherapy? Well, first of all, it could depend on the tumor characteristics and the stage of the cancer or the size of the cancer. Some of our patients really present originally with a fairly large size breast cancer, and they may want to have a breast conserving therapy as an option for them, and neoadjuvant therapy may provide them more opportunities for that. And so more and more we're really investigating more options for whether we need to consider neoadjuvant systemic therapy. Historically, though, if you had any node positivity up front, even if you had a good response to neoadjuvant therapy, all those patients had to undergo lymph node dissection. But then we had a phase 2 trial with the ACOSOG Z1071, which we looked at different patients with breast cancer with node positivity, and really is what is the false negative rate if you do a sentinel lymph node biopsy and stop there. And what we found is that as long as we do what we call a dual tracer method in the breast cancer world, so we're doing not only the breast injection with the isosulfan blue dye, but we're also pairing that up with a nuclear tracer. And if you use both of those modalities for the sentinel lymph node biopsy, the false negative rate that we're detecting the cancer that we need to detect are at about 10%, which is what's considered acceptable rate. So when we try to combine the dual tracer method and also removing at least 2 lymph node specimens during that study will certainly decrease to the false negative rate to an acceptable rate in our field. We also, another question that usually gets discussed as well, if you were to do a sentinel lymph node and not worry about retrieving the clip node, are you always getting that particular lymph node that you needed to get? And we found from this further analysis of this trial that about 80% of the sentinel lymph node biopsies will include the clip node. But if you actually sought out to target the removal of this particular clip node that had been involved with the breast cancer, that further decreases the false negative rate to under 10% to 6.8. And that's where the concept of the targeted axillary dissection really became more acceptable. So again, let me move the screen here. ACOSOG Z1071 tells us that if you come towards the middle of this slide here, dual tracing method using 2 methods will give us better statistics as to getting the lower false negative rate with the sentinel lymph node biopsies. I want to just briefly talk about breast reconstruction options as well. So we have patients who now may choose to undergo mastectomies. Well, we also want to obviously verify with the patients that they don't have to go completely flat or have suboptimal cosmetic results, and breast reconstruction will certainly give us better options about that. But there are also different schools of thoughts or options when it comes to breast reconstruction in general, where we are able to do what's called an immediate versus delayed approach, as opposed to also an autologous versus implant based. So autologous, as you may imagine, is using your own body fat, as I explained to the patients, to be able to perform the reconstruction. And the picture here is just an example of what patients can undergo. So the picture on the left on the screen is showing someone pre-operatively, and then post-operatively she underwent the bilateral breast reconstruction using autologous reconstruction using your abdominal tissue. And so you can see the abdominal incision on her post-surgical picture. If we were also thinking about doing the breast reconstruction, historically, we almost always just thought about putting stuff underneath the muscle or subpectoral. And that can, even though that's still considered somewhat of the standard therapy, that can have differing outcomes as opposed to what we call a pre-pectoral placement of tissue. And this is just the illustration where, typically breast tissue lays, the native breast tissue lays underneath the muscle, and some of the reconstruction can certainly replicate that, where you're placing the tissue expander underneath the muscle, and to be able to expand that pocket over time with the introduction of the fluid, and over time you can certainly replace that with an implant under the muscle into that pocket. All right, thank you so much.
Hi, my name is Dr. Kamel Abu Hussein. I am from the Department of Medical Oncology at Cooper University Hospital, and I was asked to comment on the same case presentation from the medical oncology standpoint. So we are looking at a young 38-year-old female who had a palpable right breast lesion, who has a positive family history with her maternal aunt being diagnosed with breast cancer. And she did see some delay in diagnosis and getting the right workup done secondary to COVID, as many other patients, unfortunately. And what complicates the case even more is issues related to unemployment and losing one's insurance. The patient had a biopsy confirmation of her right breast cancer, which was consistent with involvement with triple negative breast cancer, which involved the lymph nodes also. Now, an important question always is to keep in mind what are the common indications for referral of patients who are newly diagnosed with triple-negative breast cancer for neoadjuvant or preoperative chemotherapy. And the most important one is by size criteria. So most organizations, whenever there is a triple-negative cancer that is between 1 to 2 centimeters, they will have a low threshold for such a referral. Any patient who has a positive lymph node, patients who present with an inflammatory breast cancer type presentation. Also, if you have a small tumor that is in a tricky location that is abutting the chest wall and you would like to achieve negative margins from surgery, of course, that's another indication. And in patients who have a small sized breast, so the tumor to breast ratio is on the larger side. All of those would be reasonable referral indications. Typically, we would treat those patients with a chemotherapy regimen that is anthracycline-based. So the common regimen that we use a lot in practice is anthracycline along with Cytoxan, followed by paclitaxel and with or without carboplatin. For such a patient with lymph node involvement, it's really important to also arrange for staging scans, and that could be with a PET scan or a CT scan of the chest, abdomen, and pelvis, and a bone scan. It's also important to keep in mind when is it important to refer your patient for genetic testing. And recently, we've seen a change in the indication for triple-negative breast cancer referral for genetic testing. So until very recently, the criteria was any woman that gets diagnosed with triple-negative breast cancer before the age of 60 is a candidate for referral, but the NCCN guidelines have updated their criteria very recently, and now it is any woman with triple-negative breast cancer qualifies for genetics referral. Now, there's been a lot of ongoing clinical trials that are evaluating the role of addition of a checkpoint inhibitor or immunotherapy in addition to chemotherapy in the neoadjuvant setting in order to improve the outcome for those patients. And those are just examples of the different clinical trials. But the one that really made quite an impact and led to a change in the guidelines is the Keynote 522 clinical trial. And that one was using a medication called pembrolizumab in addition to chemotherapy in the neoadjuvant setting. And this is the design of the trial. So basically, it included patients who had a locally advanced form of triple-negative breast cancer. So they had either a large tumor, T2 to T4, or a smaller tumor with lymph node involvement. And for those patients, they randomized them into a 2-to-1 fashion. Everybody did receive the same chemotherapy, and the chemotherapy was starting with weekly carboplatin and Taxol, followed by doxorubicin and cyclophosphamide. And the first arm did receive pembrolizumab every 3 weeks in addition to that chemotherapy backbone, and the second arm received placebo. Then everybody proceeded with surgery, and the pembrolizumab arm continued with maintenance pembrolizumab for 9 more cycles after surgery, and the other arm continued with placebo. And we did see an improvement in an endpoint called pathologic complete response. And the definition of that is inability to detect any residual cancer in the breast and no residual cancer in the lymph node. So complete disappearance of the tumor cells. That is thought to be a very meaningful endpoint in this disease, and it did translate into a benefit when it comes to event-free survival. And that led to the approval of the addition of pembrolizumab to that chemotherapy backbone as a regimen that is thought to be best for those patients at this point. Now, I would like to review a few other ongoing trials and trials that have reported some results recently in this patient population. One of them that was very interesting is a Neuro trial. And this is a trial that is using one of the PARP inhibitors, talazoparib, in patients who have germline BRCA mutated triple negative breast cancer. So basically, they took patients who have triple negative breast cancer who tested positive for the germline BRCA mutation, either BRCA1 or BRCA2, and they did treat them with the PARP inhibitor talazoparib, which is 1 milligram daily, for a total of 24 weeks prior to surgery. And then they took them to surgery with the intent of evaluating who achieved pathologic complete response. And the results were really impressive. About 50% of the patients were able to achieve pathologic complete response without any use of chemotherapy. Now, that is really major because we are sparing those patients all the significant toxicity they would get from systemic chemotherapy. And they got a result that is exactly comparable to the effect of intense chemotherapy in this patient population. Another important landmark trial is the CREATE-X trial. Now, this is one of the very important practice-changing trials that studied basically patients who had breast cancer that is HER2 negative, so it did include both hormone receptor positive and triple negative patients who had a locally advanced form ranging between stage 1 to stage 3B, and everybody received neoadjuvant chemotherapy. And then after that, everybody proceeded with surgery. And the patients that did not completely clear their cancer, so the ones that had residual cancer, were randomized to either continuing with the standard of care at that point or receiving an oral form of chemotherapy called capecitabine. And they looked to evaluate both disease-free survival and overall survival. Now, you will see some improvement in the overall cohort, and there is some separation of the curves. So here, the disease-free survival did show an improvement with the addition of capecitabine with a hazard ratio of 0.70, and the overall survival also did show an improvement in the overall cohort with 0.59. Now, the real benefit was shown specifically in the triple negative subset, where we've seen an improvement in disease-free survival going up from 56% to almost 70% with a very nice hazard ratio of 0.58. And when it comes to the overall survival, we did show an improvement from 70% to almost 79% with a hazard ratio of 0.52. This is a practice-changing trial. Now, another trial that I would like to quickly review is the Olympia trial. This is a trial that included patients who carried a germline BRCA1 or BRCA2 mutation. So it had, again, hormone receptor positive and triple negative patients that were high risk to start with. So those are patients that had between stage 2 and stage 3 breast cancer. And it included patients that received neoadjuvant chemotherapy and ended up without achieving pathologic complete response. So that makes them high risk. And if the patients did not receive neoadjuvant chemotherapy, they must have started off with a significant disease burden. So those patients either had equal to or more than T2 lesions or had lymph node positive disease. Now, this study took those high-risk patients and it randomized them 1-to-1 to either receiving olaparib 300 milligrams twice a day for 1 year versus placebo. And the endpoint primarily was to measure invasive disease-free survival, and the secondary endpoint was to evaluate distant disease-free survival and overall survival. as you can see here, the invasive disease-free survival did show an improvement over the course of 3 years. It went up from 77% to 86% with a hazard ratio of 0.58. And the overall survival did show about 4% absolute benefit with a hazard ratio of 0.68, even though a modest improvement, but this is a very high-risk patient population. Again, this was a practice-changing trial. So in summary, right now, we think of immunotherapy in addition to chemotherapy as the new standard of care in our early stage triple-negative breast cancer, and that is based on an improvement in the ability to achieve pathologic complete response. We know now that 1 year of adjuvant olaparib did improve the 3-year invasive disease-free survival in our high-risk germline BRCA mutated patients. And we also remember that germline testing is a strong indication for all of our triple-negative breast cancer patients. So we're left with so many options. But the goal here is to tailor the type of systemic therapy that you're going to choose in order to maximize your clinical benefits and minimize any adverse events, and also keeping in mind the financial toxicity that the patients could be burdened with. I hope this has been of help, and we'll continue with the rest of the disciplines for review of the same case. Thank you.
Good evening, everyone. I am going to be discussing the survivorship care of this 53-year-old with metastatic breast cancer. Although we don't often associate survivorship with patients with metastatic disease, we know that from the definition, someone is a survivor from the moment of diagnosis, and this continues through the remainder of life, whether they are cured of their disease or whether they are dealing with it on an everyday basis. The definition does not just include the survivor, but also the people involved in their care, including caregivers, families, and friends, because we know that they face similar issues as the survivor, including the emotional impact of the disease, financial constraints, sometimes due to job loss or to other issues with paying for the care, as well as stressors associated with the survivor's diagnosis and treatment. Metastatic cancer patients are survivors with special needs who are often staying stuck in the living with cancer, also known as the acute stage of survivorship care, where the focus is on treating the disease and trying to control it. Black women are more likely to die from breast cancer than any other group, and they also face a myriad of challenges throughout the continuum of their care, which can affect their outcomes and their quality of life. For this reason, we want to make sure that we pay special attention to the needs of this patient. We know from the literature that Black women with breast cancer face many disparities that can have a negative impact not only on their options for treatment, but also on their compliance with treatment and their outcomes. This can include things, especially for metastatic breast cancer, such as out-of-pocket cost. If someone has a high copay and they have continuous copays and visits throughout the year, this can accumulate and really make an impact on that person's financial burden. There can also be other healthcare costs, including costs for their medications, not only the medications for their treatments, but also the medications for their symptom management. That can also have a negative effect on that person's ability to pay not just for their medical costs, but also for their everyday living. Anxiety and worry can especially impact our patients with metastatic disease. Every time that these patients have a new symptom, it can be concerning. Every time that they're waiting for their tumor markers that can come back, that's a new worry. Every time that they're waiting for their staging results to come back, that can be a big anxiety-provoking time. So these patients deal with this constant anxiety and worry throughout their treatment. Transportation for the many visits that they sometimes need to be attended can also be an issue, especially if they need a companion and cannot drive after their chemotherapy appointments, or if they're very fatigued or they're having severe other symptoms. There can be work-related concerns if they can no longer carry on their normal duties at work and either lose their job because of this or are unable to continue to maintain their job, because this can ultimately sometimes lead to loss of medical insurance that can impact the treatments that they receive in the future. We also need to pay special focus to the symptoms that our patients with metastatic breast cancer are having, and make sure that we manage it in a way in which they feel comfortable and improves their quality of life. And finally, for this patient who has many other healthcare issues and the treatments that we give can worsen these, we want to make sure that they stay in close contact with their primary care providers to help manage some of these symptoms. The research has shown us that Black women with breast cancer feel that their pain is not well controlled. This is especially shown in women in which there is lack of a spiritual well-being. So when we're looking at the physical dimensions of pain, that physical dimension can be affected by other things around it, such as social, emotional, and spiritual concerns. As such, it is really important that we not only address the physical pain and we treat the physical pain, but that we also discuss some of the other things that could be impacting her physical well-being. Is she having issues with her social network? Does she have the support that she needs to continue to get through her metastatic treatment? Emotionally, how is she dealing with having metastatic disease and not knowing what is going to happen in the future and what will happen with the care of her two teenage boys? And spiritually, has she become hopeless? Does she need support in making sure that her spiritual being is feeling well and is being fed while she's dealing with her treatment in this disease? End-of-life discussions are difficult discussions for many providers, but we know that it's never too early to discuss end-of-life care. Advanced directives such as medical proxies and living wills allow our patients to have their wishes documented ahead of time so that they can live their life to the very end the way that they would like. This is especially important for our patients with metastatic disease. In order to treat this patient's nausea and vomiting and other symptoms related to her disease and its treatment, palliative medicine intervening from the very beginning is a great option. This allows the patient to understand not only what her options are medically, but also non-medical treatments. The palliative medicine team may discuss options such as acupuncture as well as things such as medical cannabis. And then understanding the patient's goals and the milestones that they're interested in reaching for this patient with metastatic disease is extremely important. We want to make sure that the goals are feasible and in line with the patient's disease and its process. And then finally, discussing hospice ahead of time is also very important. It is not to scare the patient, but to make them understand that there may come a time in the future where the focus may be not so much on treating the disease, but on treating the symptom and giving them good quality of life. Finding culturally appropriate services for our patients who are Black and who have metastatic breast cancer can be especially difficult. Nevertheless, one of the tools that we know is very helpful to these patients is having a patient navigator. In a focus group that we held with our patients with metastatic disease, they mentioned the difficulties of scheduling follow-up appointments and scheduling those restaging scans and dealing with the red tape of not only the medical insurance, but also the healthcare system. Having a good navigator in place can really be very helpful for these patients in dealing with all those issues. We also want to make sure that we address any financial concerns by finding resources to meet those concerns. A great social worker can help deal with things such as disability paperwork and understanding what the rights of the patients are when they have cancer, when they have metastatic disease. It can also help find financial support such as foundations that can help pay for utilities or gas or transportation to the visits, as well as helping deal with co-pays and other worries that these patients can have. We also want to make sure that we talk to the patient and help her understand how to share the news with her children, not only that she has breast cancer, but that she has metastatic breast cancer. This can be done by having the children come in and speak to a team member that can help address their questions and concerns, or having the patient get educated about how to share the news with her children and her family. When recurrences occur, there may be a need to meet again with these children and family members to discuss again where the patient is and where her disease process is and address all their questions. Complementary medicine is a great way for the patient to remain active and also to meet with other patients who may be in the same area where she is in her disease process. We know that patients who are physically active as much as they can within their disease process can help deal with issues such as fatigue, such as anxiety and depression. And then behavioral health is a great way to help address the psychosocial concerns that the patient may have, as well as learn some coping strategies to deal with the daily concerns and the daily issues of living with metastatic disease. And finally, making sure that we're actively listening to our patients. This leads to patients that are engaged and patients who really have their preferences and values understood so that they can be shared decision making in a patient-centered way.
Thank you to our panelists. We are going to bring the panelists on for a Q&A. Okay, so thank you again to our presenters. That was an excellent presentation. We will just take a couple of questions so that we can move on to case number 2. The first question is, as a radiologist, Latina, what can I say to a patient that is Black that will get her to realize how important it is to take care of her breast health? When I encounter them or the patient during a diagnostic mammography session, I feel like I want to capture her and educate her. Is it wrong to do that? I am often not sure if she will be upset if I seem to focus on the fact that she is Black. Does that make sense? Dr. Babag, Amy, you want to answer that?
Yeah, I think, can you hear me?
Yes, we can hear you.
Okay, sorry, I just lost my mic for a second. 1 second.
Okay, no problem. I think that I'd like to get Dr. Babagdami's perspective on that as a breast imager. We'll let you have at it.
Yeah, so I think that's an excellent question. So I think it's actually perfectly a great time to actually educate our patients when we have them in front of us, because we have a captive audience at that point. So I found in my experience that once patients see me and they can identify with me, and I give them, information, that they're very willing to accept that. Even if I say, as a Black woman, or as a Latinx woman, you are at elevated risk than X, Y, and Z. And often they sit down and they ask me questions. And this is my chance to talk to them about the importance of getting their mom, their sister, their cousins, asking about family history and the need to talk to their doctors about their risk for breast cancer. So I think it's a perfectly good time. And this is the one time we have as radiologists to have a captive audience. So I do it quite frequently.
Thank you. Are there any other comments to that question?
Yeah,
All
I
right,
can
so-
just, oh no, go ahead.
No, please.
I just wanted to echo what Dr. Bababari was saying, that when you shouldn't second guess your instincts, right? I think it's great that you show so much concern, and it's okay to show concern. I think throughout our training, we've been taught to be kind of even keel, steady emotions, but when a patient sees how much you care, I think they can't help but to take that seriously. So don't second guess the concern and the passion that you have when it comes to caring for these women.
Dominique, let me just ask you really quickly. I know that you are not of age or weren't of age to be screened, but how would you feel if one of your providers or physicians, I hate using the word provider, so sorry, one of your physicians came to you as another minority and said, listen, you have this disparity exists, and want to talk to you about X, Y, and Z and encourage you, how would you react to that?
I think that I would appreciate it. I think it's something honestly that I never experienced before, so it might, be a little shocking, but I think that I would absolutely appreciate it in the long run and be grateful for that.
Yeah, and I would add to that probably it'll be a lot easier getting that, for example, that feedback from a provider that you can identify with. So if there is a difference in background, whatever it is, I think it all boils down to building trust with our patients, as we alluded to before. Now, the second question is a really important one, and it has to do with features that would make us want to screen or look at patients at an earlier age. So if you start the evaluation at age 30, what identifiers will cause you to recommend mammography? Is it the family tree? It's unlikely that many will come in with a history of family member having BRCA genetics, since they don't get tested often. I'm assuming they're also doing physical exams at 30. So for that question, I think, again, for radiology and surgery, input would be really important. Let's start with Dr. Flannery.
Yeah, absolutely. So I think that there's also another question about this whole idea as to the surgical options. I think in general, as I was almost going to say provider, but as a physician, we have the due diligence to obviously provide all of the options that are afforded to the patient while being sensitive to not only how the patient is presenting from a medical standpoint, but social standpoint and other factors. And, as a minority physician that happens to not be a Latina or African American physician, I still do, I think, take care of a lot of minority patients in general. And what I have found that is typically, honesty, I think, really is appreciated by the patients. I am very frank at the time of the visit when I speak with them as to what the surgical options are, what the oncology options are. And then if I have any specific question, I think that being direct with your patients actually is appreciated. I recently also took a lot of implicit bias training that really opened my eyes in ways that I just never imagined. I'd always thought that as a fellow minority physician, that I was cognizant of what happened in our society, and it was really eye-opening for me to participate. And again, when I ask my patients, they do appreciate our candor the most, I think, and that's something that we all should really strive to practice.
Perfect. Thank you so much. Dr. Babigmi, could you please comment on some of the radiologic features that would cause you to recommend early screening?
Yeah, so often when patients present to us and we see findings that are suspicious for breast cancer, is the time I talk to them about their family history, if they do know it. Most of the time in our patients of color, many times it seems taboo not to talk about breast cancer or screening for breast cancer. So I encourage my patients when I see them, if they're the ones I'm seeing at that time, to talk to other family members about the fact that they're going through this process. And if they're willing to talk to those patients, that I can say, look, if they're willing to talk to me, I'm happy to talk to them about their need for screening and what next they need to do to talk to their primary care provider. Because now that you have breast cancer and this is your sister or this is your mom, you should know that you are somebody who might be at elevated risk. So, not specific to the features on the imaging, but the fact that I have a patient in front of me that might be the index patient for that family and can be a source of sort of a cultural change and getting other members of the family to come in for screening. So I have patients who now come in with their sisters or who have, given my phone number to their daughters and things like that. And that's how we spread the word from the radiology point of view and then back to the providers in asking for their screening referral.
Perfect. So I think we have other questions, but for the sake of time, because we have another case, we'll move on to our next case, and then we'll answer the rest of the questions afterwards.
My name is Dr. Kemi Babagbemi, and I will be discussing case 2 from a radiology perspective. History given to us is as follows: 53-year-old with past medical history that's significant, worsening headaches for 6 weeks associated with nausea and vomiting. Patient underwent MRI imaging, chest, abdomen, and pelvis, CT, and then subsequently underwent physical exam, discovering a 3.5 centimeter breast mass without visible axillary adenopathy. Brain MRI performed on the patient using contrast demonstrates marked areas on the fluid-sensitive sequences of marked edema in the right posterior frontal and parietal lobe, as well as in the left frontal lobe. The lesions underlying the area of edema are appreciated post-contrast as ring-enhancing masses identified posterior frontal, right parietal, and also in the front of the left frontal lobe. Chest CT on the patient performed detected multiple solid masses / pulmonary nodules as identified here in both lobes on the right and on the left posterior lung. Incidentally, a mass is seen in the soft tissue in the breast. Abdominal CT on the patient demonstrates multiple low-density masses with a dominant mass measuring up to 4 centimeters in the right hepatic lobe. Subsequent mammogram performed demonstrates an irregular high-density mass that measures approximately 3.5 centimeters with irregular spiculated margins. I've included the contralateral breast for comparison. There is no visible axillary adenopathy on the mammographic images. The ultrasound performed demonstrates a solid irregular mass with areas of focal increased vascularity and surrounding tissue edema. Mass again measures 3.5 centimeters, and an ultrasound-guided core biopsy pathology yielded invasive ductal carcinoma. This patient also had an MRI. I've included this for completeness.
irregular solid, mildly enhancing mass identified in the outer portion of the breast. So the imaging, according to the ACR, American College of Radiology Appropriateness criteria, the initial imaging examinations to determine extent of disease or tumor size in the patient who is going to be a candidate for neoadjuvant therapy is mammography with digital breast tomosynthesis, ultrasound, and MRI of the breast. The MRI is the most sensitive and specific test to determine the response after completion of neoadjuvant chemotherapy. But if this is going to be used, the patient needs to have had a pre-treatment MRI for comparison. The mammogram, DBT, and ultrasound can be used to monitor response if the index lesion is previously well defined on that imaging and tumor extent is fully characterized in the pre-treatment setting. For the assessment of the axilla, as was done in this patient, axillary ultrasound serves as the best modality to assess axillary involvement. But MRI certainly may be better for the assessment of the chest wall on level 2 and level 3 nodes. So the imaging of metastatic breast cancer varies according to the disease stage. In early breast cancer, the incidence of distant metastasis is less than 2% compared to 15 to 20% in stage T3 to T4 carcinoma. Imaging is therefore not recommended for the initial imaging of newly diagnosed asymptomatic patients with stage 1 breast cancer to rule out metastases. In looking for metastases for breast cancer, the most common sites are going to be bone, lung, breast, and brain and liver, About 10% of patients with metastatic disease will have lesions at multiple sites. We tend to use the ACR appropriateness criteria, which is an evidence-based referral and clinical recommendation site to determine the best imaging for patients. And as you can see, in a patient where there's known cancer and suspicion of clinical metastatic disease, staging or assessment of response to neoadjuvant chemotherapy, the initial imaging evaluation could be bone scan combined with CT chest of abdomen and pelvis, as well, or could be FDG PET and CT of the whole body. These get the superior rating of a 9, the chest, CT, abdomen, and pelvis about an 8. So as I mentioned, based on the criteria, initial assessment, CT, chest, abdomen, and pelvis is commonly used to stage patients with newly diagnosed locally advanced breast cancer or to assess for recurrent carcinoma. The bone scan is the standard imaging test when there's need for assessment for bony metastasis. A recent study suggests that the PET-CT may be more useful for stage 3B or operable 3A tumors and for specific tumor types. For patients with stage 3A or higher disease, regardless of whether symptoms are present or not, the whole body CT or alternatively a bone scan as well as the CT chest, abdomen, pelvis should be considered. In patients with inflammatory breast cancer, regardless of stage, they should also undergo imaging evaluation. So staging with PET-CT detects distant metastasis with a sensitivity of anywhere from 50 to 100% and a specificity of 50 to 97% in patients with advanced breast cancers, some of which might be occult in conventional CT imaging. And one particular study led to changes in the clinical staging of about 52% of those women. So given that 8 to 14% of women with locally advanced breast cancer have distant metastatic disease, PET-CT in some cases may be preferred over conventional CT imaging. And in addition, PET-CT has been shown to be superior in detecting internal mammary nodes. So basically, in summary, staging and assessment of response to chemotherapy with locally advanced disease or suspected metastatic disease, either a whole body PET-CT bone scan combined with a contrast-enhanced abdominal CT remains the standard, with a choice primarily varying with institutional preferences. In our patient, where there was a specific suspicion for brain metastasis, the brain MRI with contrast is the best modality for localizing brain mets and for assessing response to treatment. Because the MRI with specific sequences such as diffusion and perfusion MRI can also be used in differentiating between recurrence and post-treatment changes. So the imaging modality remains MRI compared to head CT because CT tends to be less specific. And in this particular scenario, the FDG PET does not add any significant additional information. So most of the brain mets that we see in imaging frequently from lung cancer. Breast cancer represents about 15 to 20% of the mets of the brain that we see. And the brain mets in some cases can be the initial disease manifestation in a cancer of unknown primary. The risk of metastatic disease to the brain is usually highest for women with the more aggressive subtypes of breast cancer, such as the triple negative or the HER2 positive breast cancers. In assessing for lung or pulmonary metastases, we also find that multiple malignancies can metastasize to the lungs. And these, of course, include breast cancer, colon cancer, prostate cancer, bladder cancer, and Wilms tumor. Often the lung metastases we see on imaging are an incidental finding, but when the metastases do cause symptoms, they often include pain or discomfort in the chest, shortness of breath, wheezing, a persistent cough, or coughing up of blood or mucus. Chest x-rays can certainly be used for initial screening for these patients, but the plain films are typically insensitive to finding small lesions and may only be useful if the lung metastases are large and numerous. Chest CT, therefore, is the mainstay imaging modality, which is employed for the detection and follow-up of lung metastases, and it's also quite useful for the assessment of mediastinal adenopathy. It's important to note, though, that the manifestations of metastases in breast cancer in the chest can involve both the pulmonary parenchyma, the airways, the pleura, and the thoracic lymph nodes. They may occur as either solitary or multiple lung nodules, as we saw in this case. The nodules could be endobronchial. They could also be lymphangitic spread, or they could be consolidation of air space. When we see pleural disease in breast cancer, it can occur as pleural thickening, nodularity, or fusions. The chest CT also can be used to monitor treatment response and also assess treatment-related complications. Liver metastases, as we saw in this patient, can also be assessed using cross-sectional imaging. Most of the liver metastases we see are from colorectal cancers, particularly because the blood supply from the bowel is directly connected through the portal vein. Liver metastases come from a varied source of carcinomas, but they can occur in up to 50% of patients with breast cancer. When there's a specific abnormality in a liver function test, such as an elevated ALK phosphatase, abdominal pain, or other reasons to suspect liver involvement, the chest CT of the abdomen and pelvis is typically the test of choice. In some instances, depending on the specific symptom that's being evaluated, abdominal MRI or ultrasound could be used. So in assessing for metastases, liver CT versus MRI certainly can be considered. The liver MRI tends to be better sensitivity in the background of hepatic steatosis or fatty liver. It often can be used to improve the characterizations of lesions that are not properly defined or characterized on a CT. And because in MRI you can use hepatocyte-specific contrast agents, MRI can be used to distinguish between masses like FNH from metastatic disease. For patients with localized bone pain or elevated ALK phase, the recommendation is to obtain a bone scan. If the bone scan is negative and there's a clinical suspicion that warrants further evaluation, MRI may be performed localized to the symptomatic area. Overall, PET-CT in this setting has a diminished ability to detect bone mets, but it may be better for assessing marrow involvement, for differentiating between a flare phenomenon or true worsening of disease. MRI tends to provide a higher resolution and can be used to assess extraosseous involvement, particularly involvement of soft tissue. I've just placed here just an example image of an unremarkable bone scan, which was done in the patient that I'm using for example. So in general, FDG PET tends to have very low sensitivity and specificity when you're looking at for the assessment of the primary tumor, and it's therefore not recommended. It also has low sensitivity when you're looking in axillary lymph nodes, but certainly if there's a finding there, there's a high specificity. The value of PET-CT comes in when you're looking at extra-axillary sites, such as the internal mammary lymph nodes, and in looking for metastases. Often, though, it's important to note that sometimes the specificity for FDG PET may be heightened by using the pre-PET-CT to differentiate between benign causes of FDG avidity that may actually complicate the situation. So this is an example of a patient with a large left breast mass with an FDG avid finding that appears to be involving the lumbar spine, but on review of the pre-PET-CT imaging, it is clear that this patient has Paget disease. The FDG avidity of a given breast cancer is influenced by receptor status, the grade and histological type of the tumor, with ER-negative tumors having statistically significant higher FDG avidity than the ER-positive tumors, and the grade 3 cancers having statistically significant higher FDG avidity than the lower grade malignancies. But although these are statistically significant findings, there's considerably a lot of overlap between subtypes, and this cannot be fully used to distinguish the tumors. Extensive evidence does suggest, though, that the FDG PET-CT can detect unsuspected extraocular nodal and distant metastases in advanced local disease with a greater yield of detecting unsuspected malignancy in about 30% of the cases in stage 3 versus stage 2B. And of course, this detection of unsuspected malignancy alters staging, prognosis, and choices of therapies and management. It's important to note that the appearance of invasive ductal carcinoma and invasive lobular carcinoma may also be impacted by the FDG PET. Both the invasive lobular carcinoma lesions and the mets from those have a lower FDG avidity than the invasive ductal carcinoma lesions. The bony metastases from ILC tend to be more sclerotic and certainly could be missed by FDG PET. Invasive lobular carcinoma also differs from invasive ductal carcinoma in its patterns of metastatic spread, having a greater propensity to metastasize to the GI tract and retroperitoneum, where it's very difficult to assess just using FDG PET because these sites have a lot of overlapping physiologic and variable FDG avidity. So the FDG PET has lower rates of detecting distant SMETs in ILC compared to IDC. And this is something that the physicians who are interpreting have to be aware of as they look at these studies. Important to correlate the FDG with the CT component of the study. So PET-CT is also certainly useful for evaluating treatment response. And in the image I've provided here, borrowed from one of the journals, we see a patient who has multiple FDG avid nodules in the right breast, the axillary region, and in the subpectoral region, and also bilateral hyaloadenopathy. And the B image demonstrates that there's complete resolution 6 months post-therapy, with a significant decrease in FDG avidity, suggesting a response to therapy. Also note that there is a sacral lesion here, which has also basically resolved on the follow-up study. So that was just a brief overview of what is available on imaging of metastases in breast cancer patients. I thank you for your time, and here are my references.
Good evening, everyone. My name is Evelyn Taiwo. I'm a medical oncologist at New York Presbyterian Brooklyn Methodist Hospital. Today, I will be talking about systemic management of metastatic breast cancer. I will focus on the goals of treatment, talk a little bit about prognosis of the different types of breast cancer in the metastatic state, also discuss treatment as well as some of the important studies, and also spend a few minutes talking about therapeutic progress that we've made over the last few decades, particularly in the HER2 positive breast cancer, like in this patient that was presented in the case. So the goals of treatment in the metastatic setting really is to prolong survival, and the emphasis is on restricting and limiting treatment-related toxicity. It's really a focus on relief of symptoms associated with the disease, improving quality of life, disease stability, if we're able to keep the disease stable without it affecting and progressing in important organs, then the patient's able to, maintain a good quality of life, and many times able to continue their usual activities while being actively treated for metastatic disease. There are different ways of treating metastatic disease, but the primary treatment is systemic. In cases, we'll need local therapy such as radiation, but primarily it's systemic therapy, whether it's chemotherapy, targeted therapy with monoclonal antibodies, endocrine therapy, tyrosine kinase inhibitor, or immunotherapy. In the metastatic setting, surgery, particularly surgery of the primary tumor site, which is the breast, is not standard of care. Sometimes as a palliative measure, that could be considered, but it's generally not standard of care, since the goal of treatment is really to control and manage disease. Any sort of surgical intervention to the primary tumor is not going to lead to improvement in overall survival, and so for that reason, resection of the primary tumor, whether it's a lumpectomy or a mastectomy, is usually not something that is performed in patients presenting with metastatic breast cancer. So this is a slide that shows the different disease sites for metastatic breast cancer, and it's important just to get a sense of what type of breast cancer a patient may have when they present with metastatic disease. So if you look at the slide over here, most patients with non-triple negative breast cancer, the bones are the primary site of metastatic disease, followed by the liver, then the lungs, and the brain. However, in patients that are HER2 positive, we have a higher incidence of brain metastatic disease like we do in this patient. For the triple negative breast cancer patients, they primarily present with lung metastatic disease, followed by brain, liver, and then the bones usually is the last site of metastatic disease in this patient. It's very helpful for us when patients present with metastatic disease, just being able to assess the sites of mets so we can start coming up with a treatment plan, since the type of breast cancer, the receptor status, really determines how we're going to manage the patient systemically. So I put this slide on here really to show the improvement in overall survival that's been made, and just the progress that's been made over the last couple decades in terms of survival in metastatic breast cancer. You can see in the 1990s where 5-year survival was about 18%, to the early 2000s where it basically doubled to about 36%. We don't have actual numbers or stats, but we do know that overall survival has significantly improved when you compare to 2012. A lot of that has to do with the development of new drugs and targeted agents, whether it's antibody drug conjugates, which are used in HER2 positive breast cancer, or even in triple negative breast cancers, introduction of immunotherapy, tyrosine kinase inhibitors, and the use of PARP inhibitors, particularly in patients who have breast cancer associated genes, BRCA1, BRCA2. So, and the development of these drugs really was as a result of just multiple clinical trials where patients, we had the ability to assess the benefit and the role of certain drugs in this patients. And I bring this up just to emphasize the importance of clinical trials in all cancers, but particularly in breast cancer. This is a disease that the incidence is highest in white women in the US. However, the mortality is highest in African American women. And what's unfortunate is when you look at the clinical trial statistics, and you realize that African American women are underrepresented in this clinical trials for many reasons that we can spend hours talking about. But I bring this up to emphasize the importance of clinical trials, because we've definitely seen an improvement in survival, and a lot of that has to do with the ability to assess how these drugs work or don't work in patients with metastatic breast cancer. So this slide just shows other factors that contribute to a patient's prognosis. So their ECOG performance status, how active they are baseline, is a factor in terms of how a patient is going to do with the metastatic breast cancer diagnosis. Their comorbidities and their ability to tolerate some of the drugs, and how that interacts with some of their underlying medical issues. The hormone receptor status is a huge determinant of a patient's prognosis, and I'll talk a little bit about that in the next few slides. The disease burden, the more tumor burden a patient has, the shorter their survival generally is. And then the metastatic site is also determinant in a patient's prognosis. A patient who's presenting with bone-only disease versus a patient who's presenting with diffuse disease and brain mets, the prognosis is different. There are treatment options for all types of patients on the spectrum of metastatic disease, but the more tumor burden and the more metastatic sites a patient has, the shorter their overall survival generally is. So this slide is really just a summary of what I mentioned on the previous slide, just confirming and just stating that the receptor status and the site of disease really determines overall survival. You can see in the first box, the patients that are hormone receptor positive, HER2 positive, have the best prognosis in terms of overall survival compared to patients in the D column with the triple negative disease and who have multiple sites of disease. So managing patients with hormone receptor positive metastatic breast cancer, endocrine therapy is the preferred option for treatment. However, in patients who are presenting with what we call visceral crisis, which is basically patients presenting with severe organ dysfunction from their tumor burden, whether it's abnormal LFTs or respiratory symptoms or rapid progression of disease, in these patients, we'll give them a few cycles of chemotherapy to debulk them and then switch to endocrine therapy. In terms of choice of endocrine therapy, it's really physician's choice, since there's no data really showing that one aromatase inhibitor is better than the other. Rarely, but in some cases in patients with low disease burden, they get a single agent aromatase inhibitor. However, most patients will get an aromatase inhibitor such as letrozole and anastrozole, exemestane. They'll get that in with a CDK4/6 inhibitor. For patients that are premenopausal, they'll get a GnRH agonist such as Lupron or Goserelin. They'll get that with an aromatase inhibitor and a CDK4/6 inhibitor. And in some patients, we'll do tamoxifen as well. So I put this on here basically to show that there are many non-chemotherapy and oral options available for patients with hormone receptor positive metastatic breast cancer. Chemotherapy is further down the line where we've exhausted every targeted agent for this patients. This is a very simplified cartoon just showing how the CDK4/6 inhibitors work. They are cyclin D inhibitors, and they lead to decrease in cell proliferation. The three CDK4/6 inhibitors that are FDA approved are palbociclib, ribociclib, and abemaciclib. This is a slide showing the overall survival in patients who are are being treated with an anti-estrogen medication. In this case, it's fulvestrant, which is actually a selective estrogen receptor deregulator, in combination with fulvestrant. And when you look at the graph, you see patients who got palbociclib and fulvestrant had improved overall survival compared to patients who got fulvestrant and placebo. So this easily is our first line of treatment. One of the 3 CDK4/6 inhibitors with one of our aromatase inhibitors. In patients that are triple negative and metastatic, traditionally chemotherapy was what we gave these patients, but due to development of new drugs as a result of great clinical trials, PARP inhibitors were developed and found to really lead to progression-free survival benefit. So PARP inhibitors are generally given in the metastatic setting in patients that have a BRCA1 or 2 mutation, and these are patients that these are not chemotherapy options for triple-negative breast cancer patients. In patients who do not have a BRCA1 or 2 mutation, we have very good data for using immunotherapy with atezolizumab or pembrolizumab in patients that are PD-L1 positive. And just the progression and the development of new ways of treating triple-negative breast cancer patients has been really practice changing. It's very exciting, and I'm looking forward to development of more drugs, more targeted agents for triple-negative breast cancer patients. This is a slide showing the probability of overall survival in patients with the BRCA mutation who got olaparib, which is a PARP inhibitor, versus patients who got physician's choice. And you could see in the blue, the overall survival was improved in patients who got olaparib versus patients who got your standard chemotherapy. So this slide really just shows the progression-free survival and overall survival benefit in patients who got atezolizumab and nab-paclitaxel for patients who are PD-L1 positive. This next slide shows, once again, the progression-free survival and overall survival benefit of the drug and antibody conjugate in triple-negative breast cancer patients. What was exciting about this study was the willingness to include patients with brain mets. These are patients who are traditionally not considered great clinical trial candidates, but with the success of many drugs and improvement in survival in many of these patients, there's this willingness to include all types of breast cancer patients, which is leading to significant improvement in overall survival. Another reason to encourage our patients to enroll in clinical trials if they're good candidates for them. So the last 2 to 3 slides are on management of metastatic HER2-neu breast cancer, like the patient that was presented in the case. So generally, the median overall survival for metastatic HER2-neu breast cancer is about 63 months, but about 30% of these patients are long-term responders, where we see overall survival of up to 110 months. It's been really astounding just to see the breakthrough and the development of new drugs in HER2 breast cancer. The drugs that we use in HER2 breast cancer are monoclonal antibodies that target HER2 and ERB2 receptors that are on the extracellular, as well as tyrosine kinase inhibitors that work intracellularly. This slide just shows, once again, the astounding breakthroughs from the 1990s up until now. The first anti-HER2 drug, Herceptin or trastuzumab, was approved in 1998. And you can see since then all the different drugs that have been approved for just HER2 positive breast cancer. Prior to the development of these drugs, HER2 new positivity was considered a poor prognosticator in terms of breast cancer survival, and now it is considered a good risk. It's considered good risk disease to have HER2 positive receptors. So from Herceptin to lapatinib to TDM1 to magituximab and tucatinib, which has been just the new exciting drug for managing patients, particularly patients who have HER2 positive breast cancer with brain mets. The tucatinib study included metastatic breast cancer patient and patients with brain mets, which had never been done in HER2 positive breast cancer, and it was intentional. They made a decision to include this patients where you could see that the progression-free survival at 1 year was 25% versus 0% in patients who got tucatinib with Herceptin and capecitabine, which is an oral chemotherapy drug, versus patients who got a placebo. So this is the trajectory, this is the future, and there are many options for this patients. So in summary, metastatic breast cancer is treatable. The goal of treatment is to control disease, palliate symptoms from the disease, improve quality of life, as well as extend overall survival. Treatment options include local therapy, as well as systemic non-cytotoxic and targeted agents, as well as traditional chemotherapy. Clinical trials remain important in not only identifying active, efficacious treatment for all patients, but also in understanding the biology of disease, which allows us to target treatment better. So thank you for your time. Have a good evening, and I hope you enjoyed the symposium.
Hi, everyone. My name is Rohan Ramakrishna, and I'll be presenting on continuing the presentation of this case on the concept of brain metastases, and I'm going to do this very quickly given the time. Also, my full presentation will be available, so you can download that, which will be much more extensive. So what I'm going to do is go quickly, and again, thank you for the invitation, Vivian, and the rest of the organizers. I'm happy to be involved. This is really important work. So I have no disclosures. And again, just to review, we have this 53-year-old female who presents with worsening headaches, and her MRI of the brain is remarkable for multiple brain metastases. So in 2020, how do we manage a patient with imaging that looks like this? Multiple brain metastases, lots of brain edema, and neurologic symptoms as a result. In the old days, this might be a situation where very little was done. Whole brain radiation therapy was maybe offered, and the patient would go on to have either poor survival outcome or a lot of neurologic deficits. And I'll explain why that is in a bit. But we treat this kind of patient a little bit differently now. And really, where we want to be is in the star, in this overlapping Venn diagram. You want to individualize our patient care in patients with brain metastasis, or any cancer for that matter, but marry that to the best of science and what that has to offer. And in brain mets, thankfully, we're getting more and more scientifically based options in order to be able to individualize care effectively for our patients. Now, brain metastases from breast cancer are among the most common, and one of the most common pathologies that I'll see in the brain. And one of the unique things about patients with breast cancer, which is great, is that a lot of our breast cancer patients will live a long time. And because they live a long time, they can develop a lot of asynchronous metastases, meaning that they present, not at the time of initial breast cancer diagnosis, unlike, let's say, small cell lung cancer. But can even be many years later. I have a patient who presented with her first brain metastasis 18 years after her initial breast cancer diagnosis. And we treated her breast cancer brain metastasis, and she's continuing to do well. So the bottom line is breast cancer is unique in that it can reside in the brain and stay dormant for a while, and then reactivate for reasons that remain unclear. The challenge of brain metastases are that mainly of the blood-brain barrier. As many of you know, the blood-brain barrier is extremely effective at keeping out systemic chemotherapy, large monoclonal antibodies, et cetera. And so the CNS, central nervous system, can be a sanctuary site for breast cancer brain metastasis. And that means we have to come up with CNS-directed therapy with the number of options, which I'll mention in a bit. The second challenge is that historically, brain metastases have been all lumped together, regardless of pathology. And what we're realizing is that brain metastases shouldn't be treated that way. They need to be separated by their primary histology, so that we really think of breast cancer brain metastases as a very different phenomenon from, let's say, melanoma. And so I think that's why we really need to be individual in how we manage these patients. Prognostication is really important in terms of how we decide to manage patients with brain metastases. For the interest of time, I'm not going to get really into the weeds on this classifying system, but you can watch it later if you want to. The one we currently use, which is the best fit, is called the GPA, which is developed by my colleague and friend Paul Sperduto, which was published several years ago in the JCO. And basically, the most important thing to note for breast cancer is that performance status, the subtype, and their age are the most important things that drive survival in patients with brain metastasis. So performance status being by far and away the most important thing. And so why does it matter? It's because it can fundamentally alter treatment decisions. So let's say you have this 45-year-old woman with a solitary brain metastasis in the right occipital lobe. Remember, right and left are reversed on MRIs. And her KPS is 100 with no sites of disease. Well, in that particular instance, the data, which I'll show you, suggests that the best way to treat this for local control is to resect the lesion followed by radiation therapy. An alternative, but what if their KPS was 70, but only because they were having recalcitrant seizures? Well, yes, their performance status is on the lower side, but it's being driven by the brain metastasis because of the seizures. So if we remove this and then again do radiation afterwards, we can get a very effective local control, upwards of 90%, plus palliate them from the standpoint of their seizure activity. Again, suggesting the role of surgery in that case. But now let's say someone's performance status is 50 with multiple systemic metastases, peritoneal metastases, and this lesion. Do we really want to put them through a surgery where they're going to have to stop all their systemic therapy and recover? Probably not. Probably not the best thing. And in those cases, if we're going to treat, probably non-invasive options like primary radiation therapy with radiosurgery, for example, might be the way to go versus just observation if they're asymptomatic. And then, of course, there are patients who we treat primarily with radiosurgery, but who may recur despite that. And so in their recurrent setting in brain mets, our options are more limited, though we definitely have options. And sometimes surgery is the best option to deal with that, followed by local therapy like brachytherapy. And so our goals for brain metastasis surgery are really local control, but monitoring for brain control generally, because many of our patients will develop multiple brain metastases throughout the course of their disease. And sometimes, unfortunately, it's like playing whack-a-mole over their lifetime, where we scan patients every few months, and sometimes, we'll keep finding little small dots here and there, which we sometimes follow, which we sometimes treat. But the bottom line is we need to be very vigilant and monitor these patients carefully over time to try and reduce their burden from brain metastases. Now, we have lots of treatments for brain metastases, and for anyone that's really interested in this, I'm happy to send you a copy of this. This is a text we wrote on the management of CNS metastases. And there's, bottom line, so many things we can do. We talked about whole brain radiation therapy, which was at one point the mainstay of treatment for patients with brain metastases. But the issue with whole brain radiation therapy is that it can definitely cause cognitive deficits in patients, particularly those whom we think are going to live a long time, which is a large majority of many of our breast cancer patients. And so the longer you live after whole brain radiation therapy, the more likely it is that you're going to start to develop neurocognitive issues, and that's well documented. So we try and avoid whole brain radiation therapy as much as possible. And instead, we have other options, which include surgery to remove the lesion for reasons that I went through, radiosurgery, which is very focused, precise radiation therapy. And we can do that with patients with multiple metastases nowadays using modern planning techniques. You may have heard of the Gamma Knife or CyberKnife or other LINAC-based radiosurgery machines. But those are really effective and can be repeatedly deployed in an effort to avoid whole brain radiation therapy. And then, of course, there's combination therapies where we, for example, combine surgery with either radiation given externally or interstitially with brachytherapy. For example, we use we at Cornell often use cesium, which has a great dosimetry profile and gets the dose out within a month or so when we place it into the brain, and it's very conformal. But the good news is that there's evidence that targeted therapy, chemotherapy can work in the brain. There was the recent Landscape trial, which looked at capecitabine and lapatinib in patients with HER2-positive breast cancer and showed up to a 60% objective response rate that seemed to be pretty durable. The only problem was that up to half of patients had a grade 3 or 4 toxicity. So while that toxicity profile is obviously something that needs to be improved upon, I think this is just the tip of the iceberg in terms of our systemic or targeted therapies having activity in the brain. And again, there's going to be more to come on that. So again, there's a lot of exciting developments when it comes to brain tumor metastases. I'm going to skip over this for a second, but the last thing I wanted to maybe kind of impress upon you is the role for CNS-directed therapy. And I think this is a big future in brain metastases care. Specifically, there's this idea of clones and how these clones from the primary tumor take up residence in the brain. And these clones can be different genomically from each other. And one of my colleagues at MGH, Priscilla Brastianos, published a great paper about 6 years ago now looking at genomic characterization of patients with brain metastases. And one of the things you realize is that the brain metastases in these phylogenetic trees are distinctly different from their parent tumor, which brings up the point that they can be genomically targeted in a separate way. For example, it's well known that some of the brain metastases can lose HER2 signaling in the brain. And the second thing that she found was that the brain metastases were all, even if you had 3 or 4 of them, were similar to each other. So of course, if you wanted to do CNS-directed therapy and all the brain mets were different from each other, then you couldn't really do much. But what her data shows is that while the brain metastases are different from each other, or different from the primary tumor, they're similar to each other. And that, again, supports the role and encourages development of treatment strategies that have CNS-directed therapy at its center. So if you take the same data and reclassify not by the primary histology, but by whether those same brain metastases had sensitivity to either CDK inhibitor, PIK3 inhibitor, or a MAPK pathway inhibitor, up to 53% of patients would have a targetable mutation. And so tissue really is the issue when it comes to brain metastases care now and in the future. And I think one of the things in terms of trial development, as difficult as it is to figure out how we can combine therapies. And the particular scenario that I think we're all familiar with is when patients have controlled systemic disease. And so, the treatment they're on is working, but they have progressive CNS disease. And so is it really fair to say they progressed when the drug that we're giving them is keeping their systemic disease at bay, but just can't get into the brain? And so they're progressing into the brain. So these additive therapies, I think, will be essential towards developing new treatments and new treatment paradigms for our patients. So I think I'm just going to stop it there in the interest of time. Again, for those of you who are really interested in brain metastases, I'll just tell you that we have a number of trials at Cornell that are looking at using radiation therapy and immunotherapy together. This is being run by Dr. Fermenti, who's our chair of radiation oncology at Cornell, hoping to induce the abscopal response. Again, you can hear this in more detail in my presentation if you download it. And we're seeing some interesting results. So that's one thing to mention. The final thing is that when it comes to disparities in care in particular, we've spent a lot of time and effort and people resources to really create brain metastases care that's holistic, that's accessible for everyone, just whether you're in Queens or Brooklyn or Manhattan. But it takes a village. And I think one of the real reasons that we're able to deliver really good care, we hope, is that our patients have access to this suite of professionals and experts. And I think this is where we can see a lot of disparities between well-resourced cancer centers that have multi-D brain metastases programs and those that don't. And I think it's incumbent on us to develop these kinds of centers in any place that treats cancer. So I'll just finally say that in this particular case, we ended up operating on the brain metastases and then following it with radiosurgery. This was her scan 18 months later, which just shows, treated resection beds, and she did great. So I'll stop there. Thank you.
Thank you so much. Thank you, Dr. Ramakrishna. And as he said, Dr. Ramakrishna is an award-winning neurosurgeon, and he did write a book, so reach out to him if you want a copy. I'm going to invite our other panelists. I realize that we are over time, so we appreciate your sticking with us. We just have so many sort of things to talk about, and so we didn't want to cut off any specialty because all of this is very important. I wanted to start with introducing two other people that we didn't get an opportunity to introduce. Dr. Evelyn Taiwo, she's a researcher and a medical oncologist at New York Presbyterian Brooklyn Methodist Hospital, and Dr. Eleanor Walker, she is a radiation oncologist with clinical interest in breast, prostate, and radiosurgery, and cancer incidence and treatment in minority patients. She focuses on cancer incidence. We actually love Dr. Walker, and so I'm actually going to start with you as a radiation oncologist for this case. Can you tell us the best ways of sort of treating this particular patient and any disparities that could exist for this patient?
Well, I think many of our speakers pointed out the disparity that can occur if you don't have access to the latest treatment and people who have special interests and know how to handle this. This is a very active woman who suddenly developed these symptoms. I think we just had a great presentation on how the brain would be handled with combination of surgery and radiation, various ways. And so I'm not going to try and rewrite this because all of it there, it's very late. But we also have to look at her tumor burden, and she has liver mets too that can be handled systemically. But in some cases, there's not a complete response in the liver. And that's another area where radiation can be used, talking about stereotactic body radiation, where we can target the residual disease, especially if it is blocking something, to help decrease the tumor burden in this patient and improve their quality of life. The same thing can happen in a patient's lung. If a lung nodule starts to compress, for example, the superior vena cava, and that could also cause the problem with breathing for patients. And so we can use palliative radiation, again, targeted treatment, stereotactic body radiation, and the same thing in the spinal cord. We don't want a patient to get spinal cord compression. And if they have bony mets and partial compression, radiation can be used palliatively for that, or to prevent bone fractures. So there are many different ways in combination with chemo, with radiation, immunotherapy, all can be used together because our aim is to decrease pain, improve quality of life, and maintain a lifestyle for the patient that's good for as long as we can. And as has been shown with some of the studies, especially in HER2 positive patients, patients are surviving much longer. And so we have to be very cognizant of side effects of treatment. So we use combination treatments to minimize those, but yet maintain a patient's quality of life. Thank you.
Absolutely. And so I'm just going to ask Dr. Taiwo, because we were talking a little bit about quality of life earlier and what this means for patients. living with metastatic breast cancer, receiving medical systemic therapies?
Yeah, so I mean, that's usually the dilemma when we're treating patients with metastatic breast cancer, particularly patients who need systemic therapy. You know, the disease essentially becomes like a chronic illness, like you're trying to sort of, find a regimen where you're controlling the disease, but the patient's able to, if they're working, they want to keep working, you want them to be able to do that. This patient who was presented in the case has children, and so she's got a very busy life. So trying to find a regimen that's going to control disease and not really affect the patient's quality of life, because in the metastatic setting, we can't cure this patients, right? You can make an argument for how aggressive you want to be when there's a stop and start date or start and stop date with chemotherapy. But for a patient who's going to require long-term treatment, that's very important. So it's a lot of conversations with the patients. It's one thing to recommend what standard of care is. It's another thing to figure out if what you're recommending actually works with the patient who's going to need to be on treatment. For HER2 positive breast cancer patients, they can be on this regimen for 5 years, longer sometimes. So it's a huge part of the decision-making process. Quality of life is definitely very important. So I'm glad you brought that up.
You all are, we are so thankful to have you. I realize that it is late. All of your presentations are going to be available on YouTube. And certainly if there are any additional questions, please send us the questions and we will send it to the presenters. Listen, this is the second year. We have many more years to go and lots of content to bring to the table. And so while I hate to say goodbye and good night, I will say thank you all. Thank you to the survivors. Thank you to the participants and attendees. Thank you to the committee who worked so hard throughout the year to put this together. Let's see, a couple of reminders. Complete the evaluation, which will be emailed to you after this presentation. That's what you need to do in order to get CME credit. Remember, you can revisit all of the wonderful presentations and slides via the links that Nora Lee has sent. And by the way, this would not be possible without Nora Lee. So I want to give her a special shout out to our project coordinator, who has just been so phenomenal with this. And with that, we're going to ask them to do our outro and play some music. And we will see you for our third annual Breast Disparities Symposium. Be well. Take care.
Have a good night, everybody.
Good night, everyone. It's great.